Good afternoon and welcome back to GP Video Podcast by Nadia. So today we will be talking about treatment of or management of irritable bowel syndrome, because there is no curative treatment for irritable bowel syndrome, but there is definitely management plan that we can discuss. So once we have done bloods, including full blood count, CRP, ESR, CA125 and celiac serology, to exclude all the other causes that we are worried about, like irritable bowel disease, like colon cancer, ovarian cancer, iron deficiency anemia, all of that which is related to more sinistrous causes of the symptoms, which is abdominal pain and change in bowel habits. Once we have done bloods, then we have done stool test for fecal occult blood test and for fecal calprotectin. Then we can be a bit sure that when they are all negative, so the blood should be all normal, there should not be any biochemical problems, and the fecal tests should all be normal as well. We can do a CT abdo-pelvis as well to look for other causes, and the last one is colonoscopy. But people usually say, the college says that if we've done blood tests and stool tests and they are all negative, then we can be sure that, quite sure that it is irritable bowel syndrome. But if you want, the general practitioners want, they can get CT abdo-pelvis done as well and a colonoscopy as well. And if they are all negative, then we can say that, okay, it is irritable bowel syndrome. But if we don't want to go for a CT abdo-pelvis and don't want to go for a colonoscopy and specialist referral, so apart from doing bloods and stool tests, we can apply a few criteria. There is a NICE criteria, which is NICE, N-I-C-E criteria, which is from UK, and then there is another one called Rome 4 criteria. So what does Rome 4 criteria include? It includes, so the criteria is that there should be recurrent abdominal pain on average at least 1 day per week in the last 3 months, associated with 2 or more of the following criteria. So there are three criteria said, and at least there should be 2 or 3, all of them. So number 1, the pain should be relieved with defecation. So related to defecation and relieved with so usually pain is worse after eating and relieved with defecation. If it is not relieved with defecation, it generally means that it is not IBS. Then associated with a change in frequency of stool and associated with the change in form or appearance of stool. So these are 3 criteria that are mentioned. At least 2 should be there. So related to defecation, associated with the change in frequency of stool, and associated with the change in form or appearance of stool. And criteria fulfilled for the last 3 months with the symptom onset at least 6 months prior to diagnosis. Okay, criteria fulfilled for the last 3 months with symptom onset at least 6 months prior to diagnosis. Now, the management. So some adults can develop adult onset lactose intolerance and celiac or gluten intolerance. For celiac intolerance, we can do the the celiac serology, and for lactose intolerance, we can exclude lactose from the diet for, let's say, a few weeks and see how it goes. But generally, IBS can be monitored. As I said, that what triggers IBS? It is certain food, certain medications, stress, anxiety, depression, menstruation period for women, any kind of illness, they can all trigger IBS. So lifestyle management would be drink enough fluids, regular small meals, not big meals, regular small meals, adjusting fiber intake according to symptoms. So more fiber if it is predominant constipation, and less with diarrhea and bloating. So fiber should be, so as we have also mentioned that IBS is of 3 types: predominantly constipation, predominantly diarrhea, and mixed. So if it's predominantly constipation, so more fiber should be taken, and if it's predominantly diarrhea, then less fiber. Then limit caffeine, alcohol, and fatty foods. Then there is a map, there is a diet which can be followed to treat or manage the symptoms of IBS. It's called FODMAP diet, which is guided by a dietitian. Without the help of dietitian, this one is not, we are not able to follow that. That's called FODMAP. So what is FODMAP? I'll tell you a bit about it. So FODMAPs are fermentable, short-chain carbohydrates and sugary alcohols that are poorly absorbed by the body. The diet consists of elimination of FODMAPs for 6 to 12 weeks, followed by gradual reintroduction to a tolerable limit. This is difficult to follow without the guidance and support of a registered dietitian. FODMAPs do not cause IBS, but a low FODMAP diet helps alleviate symptoms in some patients. Okay, so what does FODMAP stand for? Fermentable, F, O for oligosaccharides, D for disaccharides, M for monosaccharides, and polyols sorbitol and polyols mannitol. So basically these are foods like wheat, as we spoke about celiac as well. So wheat, rye, onions, legumes, honey, apple, pears, watermelon, mango, stone fruits, sugar-free mints, and mushrooms, cauliflower. So the low FODMAP diet. So this is the diet that we have to adjust, but this is all according to the dietitian guidance. Otherwise, what we can do is we can eliminate lactose from the diet for a few weeks and then see if that helps. If that helps, then we should go with the lactose-free diet, or do the gluten-free diet for a few weeks. Then if that helps, then we should go with it. But anyways, we have to have enough fluids, regular small meals. Probiotic supplements may be considered, and reducing stress and regular exercise. While medications include loperamide for diarrhea, which is gastrostop, for constipation, bulk forming laxatives, example ispargol husk, but we shouldn't be using lactulose because it causes bloating. Then antispasmodics for cramps, which is Buscopan. So these three agents are used for symptom management. Otherwise, if we are going for more definitive management, then we can start with a low dose tricyclic antidepressant like amitriptyline 10 milligram, which is a regular one. The other three that I mentioned was just for symptom relief as needed, but amitriptyline would be a regular medication. And then according to the new research, we have liraglutide or tirzepatide, which are Saxenda and Mounjaro successively, for which are the weight loss injections. They are also very helpful. Or there is another drug called mebaverine, 1 tablet 3 times a day regularly with food. So that can also help. So mebaverine can be combined with liraglutide, and that can be combined with a tricyclic antidepressant. Or if tricyclic antidepressant doesn't work, then an SSRI, which is selective serotonin reuptake inhibitor, which is again a form of antidepressant, low dose. Like we can use fluoxetine and other drugs of this group. So thank you very much, and I will talk to you next time in my next podcast.